Okay, we're going to talk about urinary incontinence. I know you had this in fundamentals, but it's worth mentioning again because you probably forgot. So there's several different types of incontinence, urinary incontinence, and they can be mixed as well. Like you could have stress incontinence with the urge incontinence. So stress incontinence is due to increased intra-abdominal pressure. So if you look at the arrows on top of the bladder, like imagine if you're coughing and the intra-abdominal pressure increases, so it pushes on the bladder and it causes the ureteral sphincter to fail. So that's stress incontinence. When we talk about urge incontinence, there's an involuntary loss of urine when there's a strong urge to urinate. In other words, it's due to involuntary contraction of the bladder muscles. Overflow incontinence is due to either a blockage in the urethra or when there's a weak detrusor muscle, which is the muscle of the bladder. Okay, so it's overflowed. Um, Neurogenic occurs in neurological conditions such as multiple sclerosis or spinal cord injury. They could have a neurogenic bladder. The risk factors of urinary incontinence include women, especially women that have had children or multiple children because the bladder gets weaker. Neurological conditions that we've already talked about this semester, such as multiple sclerosis, Parkinson's disease, and spinal cord injury. Oftentimes they may have like a spastic bladder and they need oxybutyrin as medication to kind of calm down the bladder. It's an antispasmodic. People that are obese are going to be more at risk for urinary incontinence. Certain medications like diuretics, methylxanthines might increase the chance of urinary incontinence. Patients that are confused can have incontinence, and patients that are immobile can also suffer from urinary incontinence. Transient urinary incontinence can happen in certain conditions, and you can remember these conditions with the mnemonic diapers. So D stands for delirium, diabetes, and dementia. So in other words, if your patient becomes delirious, they may have transient urinary incontinence. Infection, especially with older adults, often the first sign that they have a UTI is urinary incontinence. And then A is atrophy of the vagina, which can happen with multiple births. P is pharmacology. We had mentioned this before with the diuretics. E is endocrine diseases such as diabetes and DI, diabetes insipidus, that you learned about at the beginning of the semester. And R is for restricted mobility. Sometimes patients may be on bed rest for a short amount of time and they may have urinary incontinence. And S is for stool impaction, which is this is a good point to drive home because you never want your patients to be constipated because that can also result in urinary incontinence. Nursing care involves getting your patient on a toileting schedule like every 3 hours or every 4 hours. Having them take most of their fluid earlier in the day. Using external catheters at night. For women, you can use the external catheter or also known as the Perwick. And then for men, you can use condom catheters. And it's not worth getting them up in the middle of the night every 3 hours because they also need good sleep. Regular bowel movements. You don't want the bowel full of stool because it's going to press on the bladder and that may cause incontinence. You want patients to keep a diary. They may have to give up things like caffeine because that can also increase your glomerular filtration rate and more urine in your bladder. And you want to encourage people to empty their bladder fully. And I already mentioned reduce or no caffeine or alcohol can also help with urinary incontinence. Intermittent catheterization is preferred over indwelling catheterization because it reduces the risk of infection. Anytime somebody has an indwelling catheter, we want to get it out as soon as possible. So we want to discontinue it as soon as possible to prevent the patient from getting a catheter-associated urinary tract infection. Okay, so that's hugely important. So if you need to teach your patient that how to do intermittent catheterization, in the hospital it's going to be a sterile procedure, but for example, like let's say a spinal cord injury patient goes home, they're going to do it as a clean technique. They're going to use clean technique. And oftentimes they'll have one of these, catheters in their purse. They carry it around with them. So I just want to point out, when you look at these catheters, see how there's no balloon at the tip? Okay, it's a straight catheter. That's why we call it a straight catheter. And the other thing is, when you look at the other end that drains the urine, okay, you notice it's just one lumen. That's another way you can tell it's a straight cath. So the straight cath is used to drain the bladder by inserting it through the urethra and emptying the bladder, just like you would with an indwelling. The difference is you drain the urine and then you pull the catheter out. You remove the catheter. And so it's used for short-term use for bladder drainage. But for those with neurogenic bladder, it may be a lifelong process that they have to straight cath themselves periodically throughout the day. All right. A suprapubic catheter is a type of indwelling catheter. However, the physician inserts it through an abdominal stoma. So it's like a surgical procedure, and it will help drain bladder. And this can be used if there's like obstruction of the urethra, like if somebody has cancer, that could be an example. And then with the indwelling, just look at the difference between an indwelling catheter and a straight catheter. The indwelling has the balloon at the end that keeps the catheter in place. And also, if you notice, it's got a port for the balloon inflation and deflation, which the straight cath or intermittent cath does not have. This is a Coude tip catheter, and you would grab a Coude tip catheter if you had a patient with benign prostatic hypertrophy. So it helps you get around the prostate gland. And if you notice, the Coude tip is curved. Okay. Now this is an example of an indwelling because it has a balloon and it has the balloon port. Okay. But your patient may need to do intermittent cathing at home, or you may need to do intermittent cathing. Remember, it's always preferred to do intermittent cathing. You may have to get a straight cath with a Coude tip if you need to do intermittent catheterization. So now we're going to talk about urinary tract infections and lower versus upper urinary tract infections. So urinary tract infection occurs usually when bacteria ascend through the urethra into the bladder. And upper respiratory tract infections is when E. coli makes its way up to the ureters into the kidney pelvis. So with UTIs, lower UTIs, we're talking about cystitis, which is a bladder infection, or uveitis, which is urethra infection. It can also mean prostatitis. And when we talk about upper UTIs, we're talking about kidney infection. So pyelonephritis is the term for that. And there's a subtle difference between them that I will point out soon. Risk factors for UTI include women with shorter urethras, and because the urethra is proximal to the rectum. Women with low estrogen levels or postmenopausal women are also at risk. People that wear synthetic underwear are at risk. People with bowel incontinence, diabetes, anybody with an indwelling catheter, and people with neurogenic bladder are also at risk for UTIs. And oftentimes they can be at risk for upper UTIs as well. And older adults are at risk for UTIs as well. The symptoms of a UTI can be remembered with the mnemonic FUNWISE, which is not really fun. Okay, so frequency. When people have UTIs, they have increased frequency and urgency. They may have nocturia. or nasty smelling urine. They may have a weak stream, intermittency, um, itchy perineal area is another symptom they may have. They may strain, and some STIs can cause the same signs and symptoms, just FYI. And then emptying incompletely, so voiding in small amounts is also a symptom of a UTI. Older adults are going to have atypical signs of a UTI, so keep that in mind. Oftentimes, confusion is the first symptom. They may, and also with transient incontinence, that could also mean they have a UTI. They could have frequent falls. They could be drowsy. They could have a poor appetite. Remember that older adults oftentimes don't generate the same type of fever as a younger person. And if they become septic, you'll see tachycardia, tachypnea, fever, and hypotension. Those are the symptoms you're looking for an older adult with a UTI. Treatment of UTI is going to include patient teaching, which I'm going to talk about in the next slide, but antibiotic therapy with either penicillins or cephalosporins. And remember, they have cross sensitivity to the allergies. If they're allergic to one, they may be allergic to the other. So like anytime you're going to give medications, you're going to check allergies. Sulfa drugs may be given. And then if somebody obviously develops a rash, they would stop the medication until they can talk with a provider. Quinolones like ciprofloxacin, okay, they're going to make the patient photosensitive, so they're at risk for sunburn, so they need to know how to protect themselves in the sun. They need to take it with a full glass of water. The other major side effect of quinolones is Achilles tendon rupture, so they need to report ankle pain. With pyridine, this is going to turn the urine orange, and we expect that, so warn the patient about it. It's a urinary analgesic, so to evaluate effectiveness, the patient would say they no longer have urgency, frequency, or pain on urination. Here are the patient teaching topics. Obviously, finish all antibiotics. Don't just stop when you start to feel better. Empty the bladder every 3 to 4 hours. Don't hold it. Void before and after sex. That's why women usually at the ages of 20 to 30, they're the largest demographic getting upper UTIs. Encourage fluids, cranberry-based products, inhibit bacterial adhesion, so that's a good intervention. Cyst baths or hot water bottles for comfort, wipe from front to back, no bubble baths, no sitting in wet bathing suits for a long time. Don't wear underclothes that retain moisture, and don't wear pantyhose, underpants, and don't wash underclothing in strong detergents. Acute pyelonephritis means somebody has an infection of the kidney. Pyleo means the pyramids of the kidney, so in the renal pelvis. Okay, it's usually one-sided when it's acute. The E. coli ascends up the ureter or makes it all the way to the kidney pelvis. Usually it's women 20 to 30, so they need to be taught to avoid before and after sex. Now, what you do need to know, that CVA tenderness, which stands for costal vertebral angle tenderness, that you would assess by percussing the flank area, distinguishes an upper UTI from a lower UTI. So in other words, somebody with acute pyelonephritis is going to have the same symptoms as a lower UTI, but also have costovertebral angle tenderness, which makes sense if you know where the kidneys are positioned in the body. Okay, now there is also a chronic version of pyelonephritis, also a chronic version of glomerulonephritis, which we'll talk about next. Also, people with polycystic kidney disease, which I haven't talked about yet, also becomes chronic. All the chronic conditions end up with chronic kidney disease. So you don't need to memorize the signs and symptoms of chronic, because it's going to be the same as AKI in the oliguric phase and chronic kidney disease. It's all those signs and symptoms I talked about in the A&P lecture for renal and urinary, and it's all the symptoms involved in a wet bed. Okay, I'm going to oversimplify glomerulonephritis. There's primary glomerulonephritis, which means it involves only the kidney, and then there's secondary. That means it could be due to people with diabetes are going to be more prone to it, people with lupus, somebody with HIV, so decreased immunity, okay? And I wouldn't focus too much on that. With glomerulonephritis, if you recall in the renal A&P lecture, I talked about the glomerulus being the filter of the nephron, and that it doesn't allow red blood cells or protein to travel through to the urine, through the filtrate, okay? So anybody with glomerulonephritis is going to have hematuria, proteinuria, and they may have red blood cell cast. A cast is just like a shell of a blood cell. You can think of it that way. Hematuria can also present as rusty, smoky, Coca-Cola, or tea-colored urine. That's the way it's described. It typically happens following an infection, especially like in younger people, 15 to 21 days after having a streptococcal infection, like having strep throat, they can develop glomerulonephritis. Again, with glomerulonephritis, it's due to an antigen-antibody complex, usually from strep throat. That's the most common infection that it can happen for. So the patient's going to have a decreased glomerular filtration rate. They're going to have an increased BUN and creatinine. Because they're losing protein in their urine, they will have a low albumin. Anytime somebody has a low albumin, the body is going to third space. In other words, they're going to have edema. Usually, the first type of edema that shows up is periorbital, so under the eye, edema. They will also have increased blood pressure, headache because of the blood pressure, weight gain, proteinuria, hematuria, oliguria, and dysuria. Okay, so glomerulonephritis is an acute kidney injury, and it's an intrarenal acute kidney injury, and I haven't discussed that yet. But what I want you to know is that when they are in the oliguric stage, they are going to have the same signs and symptoms as a wet bed that I discussed in the renal A&P lecture. So you don't have to memorize a bunch of stuff. Now, in addition to that, they will have the low albumin and the protein in the urine. Had strep is an acute mnemonic you can use about the assessment findings. So H is for hypertension. A is for ASO, antistreptolysin. That is a test that shows that the patient has strep throat. Anorexia is one of the first signs of uremia. D is for decreased GRF and dysuria. S is for swelling in the face and eyes. They could also have anosarca. That's all body swelling. T is for tea-colored urine, rusty urine, Coca-Cola urine. That's how it's described. R is for recent strep. E is for elevated BUN and creatinine. And P is for proteinuria. So all of these, with the exception of the ASO antistreptolysin, are signs and symptoms that I talked about in a wet bed. And here it is again. During the oliguric phase of glomerulonephritis, the patient is going to have the signs and symptoms I talked about with a wet bed. So make sure you are listening to that renal A&P lecture. Polycystic kidney disease, abbreviated PKD, is a genetic disorder. And healthy tissue is replaced with these fluid-filled cysts, which often burst. Okay, I'm going to talk about that later. This condition is going to progress to end-stage renal disease. In other words, they're going to go through the same phases as chronic kidney disease, and the disease is going to end in either the patient having hemodialysis. They could even get a kidney transplant, but eventually the healthy tissue is going to be replaced with fluid-filled cysts again. These kidneys can grow up to 10 pounds. So they can take up a lot of space in the abdominal cavity. That's one of the reasons we don't like to let them get constipated. So that's something you're going to have to teach them how to prevent. Okay, pain and polycystic kidney disease. If they have dull aching pain, that could mean the kidneys are growing, getting bigger. Remember I said they can get up to 10 pounds. Or it could mean that they're developing an infection. If they get sharp, intermittent pain, it could mean they have renal calculi because they're more prone to renal calculi. It could mean that um, the cyst has ruptured. So the patient will have either bright red or cola-colored urine for ruptured cysts. It doesn't mean they necessarily have an infection. Dysuria means a UTI, and they need to get that treated as soon as possible. All kidney patients should avoid NSAIDs or take the lowest dose of NSAIDs and aspirin because of the bleeding risk. And then treat with opioids or acetaminophen. PKD assessment, it makes sense to me that they have abdominal or flank pain. It makes sense they have hypertension because their kidneys are not functioning properly and they're going to end up with chronic kidney disease. So remember, all those signs and symptoms of a wet bed are going to be really important. They'll have increased abdominal girth, and with this increased abdominal girth, they're going to feel full, okay? And they'll also may develop constipation because the kidneys are taking up so much space in the abdominal cavity. So you have to teach them the proper diet to prevent constipation. And then the bloody or cloudy urine could be normal based on the cysts that are rupturing. They do need to know people with PKD are more prone to develop cerebral aneurysms. So they need to know that if they have a headache or visual disturbances, they need to call their provider right away or go to the ED because it could mean that the aneurysm has ruptured. With PKD, unfortunately, nothing is going to cure PKD. They are always going to end up with chronic kidney disease. But we can extend kidney function with some interventions. First of all, they need to manage the hypertension, so you need to teach them how to take their blood pressure. They're going to be prescribed ACE inhibitors because this decreases protein loss in the urine. And anytime you're losing protein in the urine, there's a chance that your kidney is going to get more damaged over time. You want to make sure that you reduce complications from infection, manage the constipation. They're going to have psychosocial issues, and then manage pain. Avoid NSAIDs and aspirin. They can have acetaminophen and opioids, and they can use a heating pad for abdominal pain. Diet, early there's going to be no sodium restriction because the kidneys cannot concentrate urine. And then after there will be, as the kidney nephrons start to die, they do get put on a sodium restriction. They may be prescribed tolvaptan to help improve blood flow and slow the kidney growth. They may undergo a double nephrectomy. And have a kidney transplant, but keep in mind that even a transplanted healthy kidney will develop PKD over time. And they will have to undergo dialysis at some point, and they're not a candidate for peritoneal dialysis, so they have to have hemodialysis. BPH. This is a normal finding in older male adults, males assigned at birth. What happens is the smooth muscle and the epithelial cells of the prostate gland start multiplying. It impairs the outflow of urine and can result in infection of the prostate gland. Risk factors for BPH include being male at birth, urinary stimulants like Alcohol and caffeine are urinary stimulants. That's why we tell a lot of clients with urinary problems not to drink alcohol and to not drink caffeine. Anybody that's obese is going to be more at risk. The standard American diet puts people at risk. Hereditary father with BPH puts them at risk. People with metabolic syndrome, which I talked about in the diabetes lecture, are at risk. And then people obviously with diabetes and heart disease are going to be at risk. Prostate cancer is not a risk factor for BPH. The assessment findings of BPH can easily be remembered with the mnemonic fun pissed, which is almost like fun wise, but now they have more symptoms, so they're pissed, okay? F is for frequency, so they often have to go urinate multiple times a day. Urgency, nocturia, so greater than 4 times a night is considered nocturia. They have a poor stream. They also have problems initiating a stream. So just getting started. And then I is intermittency, so urine starts and stops suddenly, or they have an inability to void. They have a sense of not being able to empty their bladder, and they strain, and they may need to apply pressure to empty their bladder, like the Creday's pushing on the bladder. Ejaculation pain or pain on urination, that is a possibility. And they may dribble and they may have dysuria. Their urine can look like they have an infection with hematuria, bacteria, and WBCs. Oftentimes they're prone to infections because they're not able to get all the urine out. CBCs will show increased white blood cells, and if they have hematuria that is constant, they could have low hemoglobin. BUN and creatinine is only elevated if they develop kidney disease from it, and I'm going to show you how that can happen. Digital rectal exam will show an enlarged, smooth prostate. The PSA blood test is a screening test offered to males age 50 or greater. So this test needs to be drawn before a digital rectal exam. They cannot ejaculate 48 hours before the test or it's going to increase the results. They don't have any food restrictions. Just in general, a PSA is expected to increase with age. If they had a UTI in the last 6 weeks, that can elevate a PSA, so you would ask about that before you schedule them for that. And then a high PSA could mean that they have prostate cancer, BPH, or prostatitis. Medications that can alleviate the symptoms include finasteride, which may take 6 months to take effect. Remember, pregnant women should not touch this medication. And then tamsulosin, remember that this can cause orthostatic hypotension, so recall what all the interventions for orthostatic hypotension are. The surgical procedure to alleviate the symptoms of BPH includes a transurethral resection of the prostate, also known as a TURP. I took care of a lot of these patients when I worked in the PACU. The surgeon takes this scope and inserts it through the urethra, and then what this scope does is it rotor-rooters the prostate, like it shaves off the prostate gland to relieve urinary obstruction. After a TURP, your patient's going to come to the PACU with a continuous bladder irrigation or a Murphy drip. I've never had anybody on an intermittent bladder irrigation after a TURP. With this surgery, with these patients, it's like Groundhog Day. The PACU is like that anyway. They wake up and they start climbing over the side of the bed because they feel like they have the urge to void. So they're a fall risk when they first start waking up. You have to remember that. The purpose of the continuous bladder irrigation is to maintain catheter patency. Because the physician had rotor-rooted the prostate, little slivers of the prostate can clog up the catheter. And then what can happen with that is the patient starts developing bladder spasms. That's a sign to you that the patient needs to be manually irrigated because the bladder can rupture if you do not take care of this problem right away. All right, so that's really important. And anybody that's had a TURP is at high risk for DVT, and you already know what you need to do to prevent DVT. Okay, I'm going to go through the continuous bladder irrigation, also known as Murphy drip. Okay, so you have a three-way catheter, and there's a 30 to 40 ml balloon inside the catheter. So it's inserted in surgery. You don't touch that. The catheter is taped to the leg to maintain traction of the surgical site and prevent bleeding. Okay? You're going to monitor the INO. You want to make sure that that irrigation is constantly flowing and draining. You want to keep the irrigation patent, and after it's DC'd, the urine should be amber in 3 days. That's something you would tell your patient. So to look at it, you have the irrigant solution, and this has a double. I'm used to a single, but it doesn't matter. It's the same principle. See how it says this is the giving set? So this roller clamp would be clamped, and then this one you would open, and you would let the irrigant flow into the bladder, and then it flows out into the urine drainage bag. That's how the constant bladder irrigation works. If your patient is having bladder spasms, you're going to have to manually irrigate the catheter, okay? So what you would do is you would take this 50 ml piston syringe and you would irrigate it with sterile normal saline. And then you would call the provider if you are unable to dislodge the clot, because again, the bladder can rupture if you don't get that clot out of the catheter. Home instructions include increasing fluid intake, no sex or heavy lifting for 2 to 6 weeks. Okay, we're going to switch gears and talk about renal calculi. Calculi means a stone, and the other name for that is lithiasis. So it could be called kidney stones, nephrolithiasis, or urolithiasis. So kidney stones originate in the kidney, but they can be found anywhere in the urinary tract. So some of the risk factors include factors for urinary lithiasis or nephrolithiasis include gender. Males are more prone to renal stones. It's hereditary a lot of times, especially when we talk about stones that are calcium oxalate stones. Also, people that have urinary tract lining that is damaged could be another cause. Also, it's unknown. That's another possibility. Extrinsic factors include like your occupation, like nurses. If you're not able to empty your bladder at regular intervals, you may be at risk, okay? And people that are not taking in enough fluid, and also diet, which we'll talk about later. There are different types of stones. Calcium oxalate is the most prevalent and from what I've seen, the most tested, okay? Calcium phosphate is another reason somebody can get stones. Struvite are due to an infection, and those are big stones usually. Uric acid, people that have trouble metabolizing uric acid could develop these type of stones, and cystine stones. Perhaps the first symptom of a kidney stone is excruciating colically, flank, or back pain. So excruciating that the sympathetic nervous system is innervated, and the patient can present with diaphoresis, tachycardia, tachypnea. They could be pale as a ghost. They can have hematuria. They can be vomiting because that's sympathetic nervous system activation. If they develop shock, which is a possibility, they'll become hypotensive. But most times, due to the excruciating pain, they're going to have hypertension. Okay, now the renal stone can cause urinary obstruction, hematuria, like we talked about. They could become infected, like kidneys could become infected, and they can develop what's called hydronephrosis. Now, hydronephrosis is when, if you look at this picture with the kidney, see there's a stone there in the ureter, so that's obstructing the flow of urine. So therefore, the kidney pelvis has got water on it, right? In other words, the urine is backing up, so we call this hydronephrosis. The danger in this is that this can produce a post-renal AKI. And I know I haven't talked about AKI yet, acute kidney injury, but that's what you're looking for if there is a decrease in urinary output. Now, the other kidney could be fine, so they could still be putting out urine, but that's something you need to look out for because oliguria or anuria is a medical emergency. All right, nursing management. That patient is going to need pain medicine. It is excruciating, colically flank pain. So either morphine or ketorolac. Hot baths and moist heat might make them feel a little bit better. They need to drink a lot of fluid to try to flush that stone out. Encourage ambulation to pass the stone. They may be given IV fluid to flush the stone out. Monitor the INO. We strain all urine, and send any stones we find in the urine to the lab for analysis so they can determine what type of stone it is. And monitor the urinary pH. That's another thing that needs to be done. Depending on this type of stone, they'll have to avoid foods. Now, the calcium oxalate is the one I would concentrate on the most because this is the most common and the most highly tested. So they need to avoid spinach or limit, Swiss chard, which is like a green leafy vegetable, black tea, coca, and Coca-Cola products types, and pecans, rhubarb, peanuts, and limit sodium. If they can't pass the stone, they may have an ESWL, stands for extracorporeal shockwave therapy. So with this, after the procedure, you would expect hematuria and flank bruising. You're going to strain all urine. There may be like some sand in it from the breakup of any stones, and you're going to monitor for dysrhythmias because it does use shockwave therapy. So monitor for dizziness, weakness, decreased exercise tolerance. If they tell you they have palpitations or an irregular pulse, that may be an indication that they have a dysrhythmia after this procedure. So it's important to monitor for that. Okay, now we're going to switch gears and talk about acute kidney injury. With an acute kidney injury, there are 4 phases. There's the onset, so in other words, whatever injured the kidney is the onset. Within usually 48 hours, you're going to see an increase in the creatinine level. And it's a rapid increase because it's an acute kidney injury. Then the patient is going to go through the oliguria stage. Oliguria means they have a urinary output less than 400 mLs in 24 hours. So they're not putting out the urine that you would normally expect of somebody. Then when the kidneys start to heal, they start diuresing. So they start losing a lot of water. They can diurese up to like 10 liters per day. So you have to make sure you're putting that fluid back in because they can die from low potassium and dehydration. And then the recovery phase can last about up to a year. And for some people, 10% of the people, usually older adults who get acute kidney injury never recover and develop chronic kidney injury. So we want to make sure we can prevent this to save people's kidneys. There are 3 types of acute kidney injury that are classified according to the causes of acute kidney injury. So the categories are pre-renal, intrarenal, and post-renal. With pre-renal acute kidney injury, this is due to a low perfusion state, like the patient got dehydrated, so the kidneys aren't being perfused. If you remember in the anatomy and physiology lecture, I talked about the kidneys getting 20 to 25% of the cardiac output. So if the cardiac output is low, or the patient, like for example, is hypovolemic shock, their kidneys are underperfused. So you're going to need to know the causes of prerenal. Most of the acute kidney injuries are due to prerenal causes. So we always want to prevent it, because remember I said that 10% of the people that get an AKI end up with chronic kidney disease, and we don't want that for people. When we talk about intrarenal types of AKI or causes of AKI, there is direct damage to the parenchyma of the kidney. So like inside the kidney is damaged. And this is due to medications, like your aminoglycosides like gentamicin, streptomycin, vancomycin, also like NSAIDs, platinum containing chemotherapy. Those can really damage the inside of the kidney, and therefore they can get an AKI. People can get an AKI. It can also happen intrarenal for autoimmune diseases like diabetes and lupus can also cause an intrarenal AKI. And then finally, the postrenal occurs because there's usually some kind of obstruction in the urinary system. And we've talked about prostate problems earlier, and that could be an example, but so can renal calculi. That could be another example, or cancer like colon cancer in the area of the bladder or the ureters. That could be another example. So that's the types of acute kidney injury. In terms of the signs and symptoms of what you'll see in a patient with an acute kidney injury, it's the same signs and symptoms I talked about in the renal A&P lecture when I talked about a wet bed. So go and review that. The one thing they may not have is a drop in erythropoiesis, because it's an acute problem. And remember, a red blood cell lives for 120 days. So they may not develop anemia, but all those other signs and symptoms I talked about, they will have, and you'll need to know the nursing interventions. And this is during the oligarch phase of AKI, and then also in chronic kidney disease. They're going to have all the signs and symptoms, including the anemia. Diagnostic testing for an AKI includes an increased BUN and creatinine. GFR is going to be decreased. They will have high potassium, so look for dysrhythmias, especially tall, peaked T waves. High phosphorus, high magnesium, and low calcium. Everything I talked about in a wet bed. They will have those electrolytes. The provider may want to do a kidney biopsy if they don't know what is causing the acute kidney injury. So go back and make sure you review the nursing implications of a kidney biopsy, because patients can hemorrhage and bleed out. So that means you need to know how to prevent that. Chronic kidney disease progresses over time, and there's 5 stages where as patients go through these 5 stages, their creatinine clearance is going to keep decreasing as they go through these stages. So stage 1 and 2, it's mild loss of nephrons. Stage 3 is moderate loss, and they have to tighten up with their diet, fluid restrictions. And then stage 4 is where it's time to get the patient ready for what they're going to do in stage 5, when it's full-blown kidney failure and stage renal disease. So in stage 4, the choices are they can either do peritoneal dialysis, so you would get them ready for that, or hemodialysis, or transplant, or they can choose a peaceful death. That's their right. So those are the stages of chronic kidney disease. The 2 most common causes of chronic kidney disease are hypertension and diabetes. And it's really important that you teach patients they need good control of their blood pressure and good control and tight glycemic control of their blood sugars to prevent kidney disease. Let's talk about health promotion and prevention of chronic kidney disease. Drinking 2 liters of water per day is helpful. This is before you have chronic kidney disease. Stop smoking, stop drinking, or limit drinking. limit NSAIDs, aspirins, or any other kind of medications that can damage the kidney. You need tight blood pressure control and tight glucose control. The other thing is people with hypertension should have annual urine tests for protein in the urine to see if they're losing protein in their urine, because that could be an early sign of kidney disease. In terms of assessment, they will have the same assessment findings as we talked about in the wet bed. Okay, so it's going to be the same as the oliguric phase in AKI and also the oliguric phase in glomerulonephritis. For pyelonephritis, if it becomes chronic, they will have the same signs and symptoms. And glomerulonephritis, if it becomes chronic, they will have the same signs and symptoms. If polycystic kidney disease progresses to chronic kidney disease, they will have the same signs and symptoms as a wet bed. Okay, the diet in chronic kidney disease involves a fluid restriction because obviously they can't put out urine, and if they're having hemodialysis, in between sessions, they still need to be on a fluid restriction. You need to restrict potassium to prevent dysrhythmias, those tall peak T waves, and deadly dysrhythmias as well. Restrict phosphorus to prevent osteodystrophy, which is when the bones get very brittle because of low calcium, chronic low calcium. Protein restriction. If before dialysis, patients with chronic kidney disease have to have a protein restricted diet because when they eat protein, it's hard for the kidneys to get rid of, first of all, but also it can make them very confused. And then they need a calcium-rich diet. So make sure you know which type of foods patients with chronic kidney disease can eat. When patients get to stage 4 chronic kidney disease, that's a time to educate them on their choices so they can have hemodialysis, peritoneal dialysis. They can also choose a transplant, but they may have to go on dialysis until a kidney becomes available. And they can also choose a peaceful death. That is their right. When patients go on dialysis, they need increased protein. So before dialysis, they need reduced protein loads. But then after dialysis, they're going to need increased protein in the diet. With hemodialysis, typically it's done 3 times a week for 3 to 5 hours. So it's a commitment. It's a full-time job. Peritoneal dialysis varies. It can be continuous. It can be intermittent. The patient can do it themselves, which is often a benefit for patients that want to travel. So those are the different types of dialysis. Hemodialysis can only be done in patients who have stable vital signs. If they don't have stable vital signs, they're going to get continuous hemodialysis, and we're not even going to talk about that. It can also be done in acute kidney injury as a temporary measure. Typically, when patients have chronic kidney disease, they will need it for life unless they get a transplant. The indications for dialysis is acidosis, so patients with chronic kidney disease suffer from metabolic acidosis, electrolyte disorders, remember the high potassium, high phosphorus, high magnesium, and low calcium, but also uremic symptoms like high BUN and creatinine. It's going to lower all those labs after dialysis. Intoxication is another indication. So patients with chronic kidney disease can't clear alcohol from their bloodstream. So that may be an indication. Or even like drugs intoxication, like for example, if they're on digoxin, they may become toxic from digoxin and may need emergent hemodialysis. Fluid overload is another indication. Uremia I've talked about in the A&P lecture, so make sure you know the signs and symptoms of uremia. Patients that are going to undergo hemodialysis need IV access so they can get a temporary tunneled catheter. Sometimes the tunnel catheter is used long term. It's a dual lumen catheter. It typically goes in the subclavian vein. It's only used for dialysis, so you can't use it to infuse IV fluid or draw blood from, and it's only accessed by the dialysis nurse. For long-term hemodialysis, the vascular surgeon will make an AV fistula, so an arterial venous fistula. And if you look at this picture, what they do is they connect a vein with an artery. And what it does is it makes this fistula that can be accessed by the dialysis nurse to perform hemodialysis. And what you would do is assess the 6 Ps. Okay, you want to make sure you're doing your neurovascular checks. You're going to auscultate for a bruit. That's how you know that the AV fistula is patent. Palpate for a thrill. Encourage range of motion on that extremity. No BPs, no sticks, no heavy lifting, no watch. They should not sleep on that side, so you need to explain that to them. They shouldn't wear jewelry, anything that could be constrictive on that side. The nursing implications of hemodialysis include obviously getting vital signs before and after and during. But you want to weigh the patient before and after, because 1 kilogram gain or loss equals 1 liter of fluid. And for anybody with kidney disease, you want to encourage daily weight so you can monitor their fluid balance. Patients are going to need labs before and after dialysis, so the BUN and creatinine should go down after dialysis. Hemoglobin should go down, and potassium, phosphorus, and phosphorus and magnesium should also decrease after dialysis. Complications to hemodialysis include hypotension, probably the most common complication. Patients aren't allowed to eat during dialysis because that can drop their blood pressure, but also just getting the fluid off can drop their blood pressure. So if they're in a dialysis chair, you make sure the head of the bed is up, and make sure you take their vital signs to confirm they have hypotension. They'll be dizzy and have tachycardia as well. Clotting of the vascular access device can also happen even with the fistula. So you would monitor for that. And then bleeding. So after hemodialysis, they cannot have invasive procedures for 4 to 6 hours because they're going to be high risk for bleeding. They use a lot of heparin during hemodialysis. So make sure you have protamine sulfate on hand and make sure it hasn't expired. Protamine sulfate is one of those drugs that you want to have in your Pyxis. However, it's not used that much, so I always used to check the expiration date when I worked in vascular lab. And then disequilibrium is another syndrome you're going to monitor for after and during hemodialysis because it involves signs of increase intracranial pressure because the patient may get cerebral edema from hemodialysis. So typically what you'll see is a headache, a change in the LOC, nausea, vomiting, and confusion. Your patient may need anti-seizure medications like phenytonin. So it's really important that you watch for these complications. Peritoneal dialysis is a great option for patients with the cognitive ability to do the procedure for themselves, especially if they like to travel. It's a good option. So what happens in peritoneal dialysis is dialysate is instilled into the peritoneal cavity. And the dialysate is ordered by the provider, and there's different combinations of fluid that can be ordered. The peritoneum then acts like a semi-permeable membrane to filter out the toxins and the electrolytes. So one exchange involves filling the peritoneum with dialysate, letting it dwell according to the provider's order, like it might be dwell for 20 minutes, dwell for an hour, and then draining the dialysate from the peritoneal cavity. Patients need an intact peritoneum to undergo peritoneal dialysis, so patients with multiple abdominal surgeries and adhesions are not going to be candidates. And also, patients with polycystic kidney disease would not be a candidate for peritoneal dialysis. The diacylate has high sugar concentration, so you need to watch for infection, but you also need to make sure you're checking their blood sugars because they could develop hyperglycemia. Now, with the outflow bag or the drainage bag, if you look at this picture, when you're draining, you want to make sure this bag is lower than the abdominal cavity so it can outflow. If you're not getting the same amount that you put in the drainage bag, roll your patient from side to side. First, you're going to check for kinks because that's the least invasive way, right? And then you're going to roll the patient from side to side. Make sure they're in a straight alignment so it can drain out. The diastole can drain out, and also make sure they're not constipation. That could be a factor in the reason that they're not draining. Nursing interventions around the peritoneal dialysis procedure. Sometimes you have patients from the community that come into the hospital that they do the peritoneal dialysis at home, but if they're sick for some reason, they come to the hospital, you might have to do this procedure for them. So again, you're going to weigh before and after because that's the best measurement of fluid balance, or non-invasive best measurement of fluid balance. You're going to check vital signs, check the glucose before and after, measure abdominal girths, and measure the input and output of the diacylate. Diacylate should be at room temperature. When patients first start with peritoneal dialysis, they're going to start with smaller amounts because over time you have to build up the peritoneum to be able to stretch. Otherwise, they're going to be in a lot of abdominal pain. And you want to make sure you explain to the patient how to avoid constipation. Complications of peritoneal dialysis include peritonitis, which can result in death. So it's really important you can identify the signs and symptoms of peritonitis, which include a fever, increased white blood cells, abdominal guarding, meaning they're in so much pain you can't palpate their abdomen, a board-like abdomen or a rigid abdomen. That's the classic signs of peritonitis. So you want to make sure you're watching out for those. Hyperglycemia, because the diacylate has high sugar. Hyperglycemia can lead to infections such as peritonitis, so that's why you have to watch that. So with peritoneal dialysis, it is strict aseptic technique. Okay, so it's really important you understand that. Poor outflow can be due to constipation. It could be due to kinks in the drainage system. So make sure that you don't allow your patient to get constipated, and that if the outflow is not draining properly, check for kinks, turn them side to side, make sure they're in good alignment. Hyperlipidemia happens over time with patients with undergoing peritoneal dialysis, and they can develop hypertension from that if they don't already have it from renal disease. Infection, so monitor for temperatures. Fibrin clots are almost expected to develop in the catheter that you do peritoneal dialysis in, and it could cause like leakage around the catheter site, so you would watch out for that too. Intestinal perforation is always a factor that you would need to watch for, and we'll be talking about intestinal perforation in our future lectures of abdominal conditions.